I invite Professor Dr. Vinoi George David from CMC Vellore. He is an experienced teacher with over 10 years of experience and providing the vision and leadership required to ensure a high quality of education for students. Dr. Vinoi sir is a professor since 2015. He is a prominent member of several national and international bodies, member of the following Fellowship of Royal Australasian College of Physicians, International Society of Nephrology, Indian Society of Organ Transplantation, and Indian Society of Nephrology. Along with the department quality managers, Dr. Vinoi is involved in accreditation of the institution with the NABH co-author for Department Nephrology Quality Manual. Welcome and over to you, sir.
Thank you, CAHO and the organization for giving me an opportunity to speak on the quality indicators and audits. I work in CMC Hospital College in the Department of Nephrology. For the next 10 to 15 minutes, the brief outline of my talk would be about the importance of quality indicators. What are the current quality indicators that are in place? How do you measure the quality of renal care? How do you define measuring? Then the next most important is how can we do better by shifting the quality paradigm, the concept of a quality pyramid that we all should include. And finally, to conclude with certain clinical audit tools in nephrology with a brief conclusion. So quality is clear and objective. Example, an adequate amount of dialysis measured by KT/V. Anemia in dialysis, ideal vascular access is an AV fistula. Evidence exists and is supported by KDOQI guidelines with significant research done bringing out these guidelines and confirming that certain standards should be met. But is that just all that we are supposed to do? Quality is actually subjective. It can be personal and it should be individualized. The quality of life, the concept of one size does not fit all. Research is not very good at evaluating another person's quality of life without allowing your own value judgments, experiences, and circumstances to get in the way. So it's difficult to assess someone else's situation because quality means different things to different people. So when it comes to a concept of reality versus myth, the quality of care or clinical performance, you cannot put it on scales, measured with a tape or scanned with a device and analyze its composition. There is no direct measures of the quality of care, unlike the human body. Hence, an abstract concept should be kept in mind. And to quantify this abstract concept, you depend on measurable aspects of healthcare, which gives you the only indication of its quality, which is referred as quality indicators or clinical performance. So having understood what we are supposed to get into, why is it so important that we should have quality care indicators in hemodialysis? Chronic kidney disease is associated with increased mortality attributable to cardiovascular events. In end-stage renal disease, the major issue the patient faces is the optimization of dialysis quality and cardiovascular risk factors. Monitoring of specific indicators is definitely mandatory. A relevant quality of care indicator should have two main features. It should be associated with a low risk of death. It should be an attainable target, which should help us to make changes in our medical practice. So the quality care indicators, what I have just classified them is into two: evidence-based quality care indicators and non-evidence-based quality care indicators. We are all doing this in all our dialysis unit. But the evidence has come out for anemia management, dialysis dose management, vascular access management. The non-evidence-based are the hypertension management, nutrition, bone metabolism, calcium, phosphorus, PTH, the middle molecule clearances, and the intradialytic hypotension management. The subsequent slide, I will just tell you what I was talking about. The quality indicators recommended by KDOQI, I have just listed it out. I won't spend time spelling it out, but I would like you to look at the right-hand side of the corner of the screen where it shows the evidence. As you see in green, why the evidence is important, because it has been done on randomized controlled trial studies, which is very difficult to do. It's difficult in a setup where we do not have adequate support in manpower and finance. But having said that, that is actually the way forward. That is where we have to help the institutions or the hospitals to do things. The subsequent ones on the red, when I said non-evidence, There is evidence, but just remember, these are based on observational cohorts, case control studies, and most of these studies have different inclusion and exclusion criteria, due to which you cannot generalize all of them to the institute, to a particular unit. So we need to take what is important for our country, for our people, and for our social culture. So these are the quality of care indicators. They improve clinical practice, no doubt. It highlights center-specific weaknesses, prompting the establishment to take corrective measures. These indicators should be based on scientific evidence. It should be prioritized that way. Others, such as hypertension, measuring LDL, you can review it, but remember, they do not reflect on patient outcomes. So measuring the quality of renal care, what are the things to keep in mind when selecting and using quality indicators? A good quality program should have the following features. It should have a case mix of indicators, not just one, but a combination of many. And I have suggested 4. The subsequent slide will do it. Once you have these case mix of 4 indicators, you should have good measurement initiatives. And I have just listed them out. You should have performance monitoring initiatives by registries, national study programs, which can be conducted by CAHO, the CQE registry study that is being done in India. They will regularly review the clinical performance based on a combination of indicators. Once you do that, then the next initiative of measurement should be a formative one. That is done internally in a hospital or in the unit. It can be done by the quality department or by the administration of the unit. They focus on the internal quality control without external interference and improving their care processes. And finally, it is a summative initiatives that need to come, especially from the NABH and especially from the Indian Society of Nephrology, where, and also with all the stakeholders in place, where these things are characterized by an external judgment of care by governments, payers, patients, etc., which are linked to direct consequences for payment or for reputation. So the type of quality indicators, which the 4 I was saying is, we should categorize our quality program should be categorized, should have all these 4 indicators. 1, a structure indicator. Now, what do you mean by structure indicator? These are characteristics of healthcare setting that affect a system's ability to meet the healthcare needs of a patient or a group of patients. For example, a dedicated outpatient vascular access service, the renal nurse to patient ratio, the nutrition patient counseling program. Is it there or is it in place? It's very important. The next indicator is a process indicator. This refers to the care that is actually being delivered. For example, do you have a timely performance of a non-invasive ultrasound for vessels for hemodialysis patients to assess the vascular access creation? Do you can even use the ultrasounds to monitor high-risk AV fistulas. Do you have an hepatitis B vaccination that is in seronegative patients? So these are process indicators. The next is the surrogate outcome indicators. Now, these are the observed parameters. This is what we are doing, the clinical correlates that we pick up, like bacteremia and tunnel catheters, mortality, anemia, PTH. The 4th one, the most important, outcome indicators, that is what is being reported by the patient on the quality of life or the satisfaction of dialysis care, are the 2 examples which comes as outcome indicators. So these 4 indicators should come in a quality program. It should be included when you assess the unit. And how do you start it? The sad part is we are stuck still at the surrogate outcomes. We only do this. We look at the observed parameters, clinical code. Are you meeting that? Are you meeting this anemia standard? Are you meeting PTH? And then we try to say that the dialysis unit is up to a kind of a perfection. Remember, the perfect quality indicator does not exist, and no good indicator covers all dimensions. So it has to be a combination of all. Now, how do you start it? All these indicators, you make it into a chain. Consider a causal chain as a start. That's called a clinical performance indicator set. Now, this set is in that chain. So the above indicators are connected by evidence, which the evidence can be depending upon the grading or the guidelines that is in place in literature. You should have an adequate case mix adjustment, not only of the surrogate outcomes. Most of the quality programs include a lot of surrogate outcomes, not looking into the process indicators. This will help you to obtain fair comparisons between facilities and within facilities over time. This will give you a correct interpretation of clinical quality measurements. What does the current literature tells us? Well, one of the good studies is which I've quoted below, which targets in clinical practice guidelines are associated with etc., are associated with improved survival. These are observational studies again. But in contrast to the other parameters, the blood pressure values, what the CAHO guidelines have been associated with increased mortality. Now, why is that? Because these blood pressure values have been taken out from the general population, not from the dialysis population in the guideline. So you cannot apply what is in the general population into the patients who are on dialysis. But having said that, the same study said multiple parameters satisfying current guidelines, except those for blood pressure, is associated with improved survival among hemodialysis patients. So there is a positive point in this paper. Finally, in 2018, the systematic review, what did it say? It says the inclusion of more process indicators than surrogate indicators would be benefit. Now, why is that? Process indicators are used for detecting changes in practice within a short period of time, that those most associated with relevant outcomes have been recommended for the assessment of quality of care. Now, this is very, very sparse. It's very little. A lot of surrogate indicators are there. Now, this is intuitive, easy to understand, easy to practice. The only thing is they just require often long-term observation to detect changes, which is doable. But if you have both, it has to be usable. It has to be feasible. So there has to be a consensus process among stakeholders, and the process-centered indicators should go into an automatic recording with electronic media records, or as the technology that has been shared by my colleague, the early speaker who had spoken, fantastic. This is what should be coming in. You should not be looking into papers and past records if you want to review anything. It should be an automatic recording. So having understood that, we should understand the quality measure for a dialysis time should have a balanced scorecard that requests everybody to move or shift to a quality paradigm. Now, what is this concept of paradigm? This shifting of the quality paradigm. Over time, the overall quality of life for patients with end-stage renal disease substantially must improve. It should not go down. There is only a narrow focus only on basic indicators of care like dialysis adequacy. Again, mainly it is biochemical and surrogate outcomes. Now, this consumes time and resources, resulting no significantly improved survival. As you can see, there can be frequent hospitalization and finally, dissatisfaction with the care experience. So the new quality paradigm should move to a more focus on more patient-centered care. This will improve their lives for the time and the money they pay for a complex therapy that they are receiving. So in patients with end-stage renal disease, it is proposed to have a quality pyramid. Now, what is this quality pyramid? The base of the pyramid should have a measuring biochemical and surrogate data. It is not sufficient to drive the primary outcomes, but excessive focuses are given on them to collect data and to meet regulatory requirements. That approach should change. You should move up in the pyramid by trying to put measures of effectiveness like quality management of fluid management, infection control, diabetes management, medication management. And what about end-of-life care measures for that individual? What does that individual want for his end-of-life care? We should have outcome measures like looking into mortality, hospitalization, and patient experience measures. And the top of the pyramid, what matters most to the patients, we should have a health-related quality of life assessment. So just showing a pictorial diagram, this is the fundamentals that we are still continuing to do: hemoglobin, iron studies, PTH. We should move up. Complex programs, you should have like medical management assessment, the qualities, the mineral bone disease, the fluid management, cardiovascular disease. That should move up to next to the measures of effectiveness. If you do that, you will know your patient's experience, how your quality assessment of their mortality and the hospitalization. And finally, looking at the health-related quality of life. Now, if we all collectively is able to articulate this quality pyramid among ourselves and in the institutions, it will give a redefinition or a relook into the kind of quality that we are wanting to do for a patient. It will help also a clinician to meet his target, to relook into his facilities that he's offering to the patient, and hence patient care improves. So a simple suggestion for an Indian clinical performance indicator set in nephrology, I've just listed out on the various 4 types of indicators. This can be improvised. This definitely can be improvised based on the unit's position and situations that they are in. And finally, coming to clinical audits, once you have a quality program in place, you need to audit your quality program. It's a valuable tool to improve quality care, and its application in nephrology is very important. Now, the question is, what are you trying to audit? So continuous quality improvement process is good, useful with a clinical audit. It improves daily care. Now, remember, the clinical audit care should contain 3 components: a clinical outcome or a process which is well defined by standards. Second, establishing using the principles of evidence-based medicine. 3, theoretical standards with daily clinical practice, which should improve the quality of care. It should be a part of an expertise of each healthcare provider locally and nationally. So there are about 5 components in a clinical audit. You choose a topic, you set the criteria and standards to follow, do your data collection, analyze it, no point stopping there, implement the changes, and re-audit your changes that you have done to see if there have been improvements. And this can be a continuous process. So the audit tools in nephrology can be patient-centered or non-patient-centered. Like patient-centered, as I said, the clinical audit of quality indicators. Non-patient-centered, dialysis stations, disinfection tools, hand hygiene tools, catheter care, exit care, audit tools. You know, these are all there in the system. But the efficacy of the clinical audit and a systematic review of the corporate, and I quoted the papers below, an effectiveness of an audit is likely to be greater when baseline adherence to the recommended practice is low, and when feedback is carried out with greater intensity. That should be the motto for a clinical audit. So to conclude, what Yogi Berra says, if you don't know where you're going, you will wind up somewhere else. So the primary goal of the clinicians and regulators should be to improve the lives of the patient on dialysis. We should have a consistent statement of what is comprehensive clinical quality care. Quality indicators should be there, a mixture of the 4 which I mentioned, with good measurement initiatives. Quality measures for dialysis, you should have a balanced scorecard. We should have a clinical practice guidelines, best published, which can be an expert domain Indian based for an Indian population. A clinical performance measures based on the above guidelines, which will be yardsticks to measure quality of care. We should have or develop the attitude to go up or shift the quality of paradigm, move up the quality of pyramid, which should be a patient-focused care. It should include more process indicators than surrogate outcomes. Remember, patients' opinions matters a lot. That is what the topmost, their self-perceived health, well-being, and quality of healthcare is important to consider. And what actually matters most, the topmost part of the pyramid, is these 3 most common answers. If you ever ask a patient, what is that you actually want now that you've reached end-stage renal disease? Some of them, you know, I had these 3 answers. I wish I could have a better life, or I wish I could be living better, or just try to treat me, just don't give me charges just to check my bloods. So a quality system should be very focused, achieving continuous improvement of quality expressed in terms of survival and quality of life, and should be based on scientific evidence. And accreditation of the unit should not be a final objective. Thank you.
Thank you, sir. Thank you so much. Really, it was an enlightening talk, and thanks a lot for being here and sharing quality audits and indicators regards to dialysis unit.